everyone. Hope you are having a great week. Brittany and I are excited to be with you this week, and we're going to talk about one of our favorite things, one of our most utilized things, I think, in our hygiene. Today, we are talking about reaching your full potential with Perio-protect trays. And before we really dig in and start talking about this, I want to talk about kind of what started this curiosity. And I'll say for me, but I know it's for us. I kind of started first and then showed it to Brittany, and she's like, wow, that's pretty cool. And we both have gotten really, really obsessed with it. But we have to first start with, let's just talk about periodontal disease in general. Okay. So we know that in 2015, the CDC came out with some stats that said that 47% of patients 30 years and older have some form of periodontal disease, and that jumps up to 70% at age 65 and older. So obviously we've got kind of an epidemic going on across our country. And again, that was in 2015. We are now in 2021, which tells me that those numbers are probably higher, right?
Yep.
And I also think we can't ignore the fact that periodontal disease has been implicated in so many other systemic issues and diseases. Research is pouring out.
Mm-hmm.
They've seen causative oral pathogens for things like heart attack, stroke, arthritis, diabetes, Alzheimer's, preterm low birth weight babies, kidney disease, respiratory infections, inhibits cancer, fighting cancer. And in fact, we got to think about it because we are in the middle of a pandemic with COVID. There was just a study done that came out that said that COVID patients that have periodontal disease are 8.8 times more likely to die of COVID.
Wow.
Of that inflammatory condition that's already present. So I feel like we've got to put that umbrella out there to just say, perio is a really big, big issue for us as hygienists. We see it day in and day out. And, it's easy to kind of get stuck in the mindset of, oh, it's some bleeding gums, it's some redness and inflammation, there's some bone loss I see on the x-rays, but it's really, really important that we understand the full systemic effect that it can have on our patients and their quality of life. And so that being said, up until about 12 years ago, the way that we would address periodontal disease would to be either to do non-surgical periodontal therapy, scaling and root planing, or refer the patient to the periodontist where they might do surgical procedures. They might do, LANAP, a lot of different options on that front. But the reality is, because this is a bacterially driven disease, and we are not actively sterilizing the patient's mouth for the long term, those bacteria take back over. And so that's why we've always told our patients, hey, we don't have a cure for periodontal disease because we don't have a cure for those bacteria. They are always going to be repopulating. And especially when we have deeper pockets and the toothbrush bristles and our floss and our water pick, nothing can really reach down there. It becomes this roller coaster effect of us doing therapy and things looking better for a while, and then those bacteria communities taking back over, secreting those toxins, and now we're seeing inflammation and bone loss again. And it's just kind of this long-term roller coaster. And I feel like we've always just kind of slapped Band-Aids on it.
Yeah. And I think that, I agree. And I want to touch back to and just back up a little bit and talk about just the deficit that there is in, treating, because I think this is such an important, I don't think that we can overshare this point. I know that we have talked about it before, and I'm sure that we will again in the future. But, according to your CDC stats, that's a lot of people who have perio disease. That's a huge portion of our population. That's the majority.
Yes.
Fall under that umbrella, but, and I want to just say, I think when we look at dental intel is intelligence, like a tech intelligence company that helps us to measure our goals, basically. Like it tracks everything from what we're doing as an office, production, collections, procedure counts, all that stuff, perio percentage, pre-appointment rate, all that stuff. And Charissa and I, our offices both use it, but I just think that it is just such an interesting stat from 2019 that I know you and I reflect on all the time. And that is that the lowest performing 10% of offices in the United States have only been treating in the year 2019, only treated 3% of their patients for perio disease. That's not even close to, that's a gross under treatment, under assessment, under diagnosis, under educating our patients. And then the average office treated 16% of their patients for periodontal disease, and the top 10% of offices treated 31% of their patients for perio disease. So as great as that is to hear, like, okay, top 10%, we're in the 30s, that's good news. It doesn't, really hold a candle to our population's needs. So this is just another way that we as hygienists can start doing whatever we can to control this this epidemic. It's just another tool in our tool belt to be able to keep this intermittent and latent disease latent. It's keep it in an inactive state longer periods of time, because we know that it's cumulatively damaging. Can't tell you how many patients that I have who have had osseous surgery and then Lanap years later, and then scaling root planing in between, and Arrestin and all this stuff. And it's just like they go home and all those anaerobes just take over in the bottom of the pocket because they've got all these factors. It's multifactorial, and it's just like, whether it's their genetics plays the biggest part for them, or their stress level, their immune health, other factors, come into it. No matter what it is for them, we've got to figure out a way to keep this arrested for as long as possible, because at the end of the day, it's not just about preventing the comorbidities, the systemic comorbidities, and it's not just about treating the perio disease for the obvious reasons. I think that the long-term effects, and when I think of my older and aging population here in South Florida, a lot of them are retirees, a lot of them are our geriatric population, and at the end of life, what really determines like a person's quality of life is their ability to communicate, to breathe, and to chew, right? So all three of those have to do with having teeth, having functional teeth. So their communication, their ability to socialize with others. Think of how important that is for aging populations, for anyone, but think of what they will lack if they don't have the teeth and the esteem or whatever they need to feel comfortable communicating and being in a social setting. So that's one aspect. And then the collapsing face, right? The collapsing face that comes with losing teeth and that shrinking alveolar bone, a shrinking ridge, and the constant even denture adjustments and partial adjustments and all this stuff. It just doesn't replace, if someone can't afford implants, it's like we've got to fill the gap, because that facial collapse can increase the likelihood of OSA, and then that increases tenfold, and it's just like this spiraling out of control thing. And then their ability to chew. Are they getting adequate nutrients? If they're losing teeth, no, they're not. They're not able to chew the things that they need, the vegetables that they need. They're not able to get adequate nutrients. So they're not those three aspects. If we think of it just in regards to dentally and functionally, like that is worth filling the void and the gap, right?
Yes.
So I think this is, you totally I feel like you opened my eyes in regards to Perio-protect. I had no idea that this technology existed. You were super passionate about it for years before I even came into contact with it, and you're the one who shared it with me, and you shared your anecdotal experience. I read up on the research on it. The research is incredible on these trays, just changing the flora in someone's periodontal pocket, just killing those anaerobes and keeping the aerobes happy, and making it so that something is disrupting that negative pattern and keeping the ratio of good to bad bacteria in check in between the times that our patients are seeing us. That's what the Perio-protect trays do. So, and I'm excited about it because I've seen your excitement and what you've done for your patients and what we've done for our patients now. And it's just like, I can't say enough good things about it.
Well, and I'm going to get into it in just a second of what exactly it is and the science behind how it works. But you might be a doctor listening to this and going, well, let's get down to it. Let's talk about the bottom line of it, because obviously we want to do everything we can to help our patients and help them be as healthy as possible. But we also have to consider, like, what's the bottom line of the practice and what's this going to do for us from a financial aspect. And I've talked to other hygienists who get a little scared, at the thought of Perio-protect. They're like, well, I make a lot of production when I'm doing my scaling and root planing. Like, what if I change to Perio-protect, what's that going to look like? And I think you and I can both speak to the inordinate increase in our production in using the Perio-protect. And it's not a replacement for, it's more of an adjunct to, but once you start using it, you see the benefits of it, and the patients are raving about it and how easy it is for them to use. And they're telling their friends and family. It's just going to drive your production up.
Yeah, absolutely. And you bring up a valid fear of like, oh, am I not going to be able to do treatment on this person? But let's go back to our why for a second and say, like, why am I here? Like, I'm here to help the person have the best quality of life, to live their best life, to be their healthiest self. So I don't think that's even like really really a consideration for most of us, but I agree that from a financial standpoint, it is totally lucrative. It totally works for the practice. It's working smarter, not harder. And it's kind of a no-brainer in my opinion, just how it's shaped our practice productivity.
Well, and I think I'm just going to throw this out there because I know, because I felt this, that I had these kind of automatic negative thoughts at the beginning when I first heard about Perio-protect, was like, what? A tray can do that? Like, that doesn't sound like that would work. So I'm just going to throw down the gauntlet and say, try it. Just try it, because I promise you, I have been using it in my practice coming up on 9 years now, and it is one of my all-time favorite things. I think everybody in the world should have Perio-protect. I wear Perio-protect. So let's talk a little bit about what it is specifically. Perio-protect is a prescription tray application of peroxide gel. And what happens is you take a patient's impressions or digital scan, they can use either, and you send that off to the lab, and they fabricate these trays that have a peripheral seal around the gum line. So the tray extends not just onto the teeth, but onto the gum line as well. And there is a very specific peripheral seal that they build into these trays. It's super cool because not only do you send the scan or the impression, but you also send their perio depth, their charting, their perio charting, because they designed that seal to force this gel all the way to the base of each of those pockets. So it's very,
if the pocket is a 10.
10, yep.
12, yes. So it's very specific. That's the most amazing thing to me is, like you said, you submit either a scan or an impression, and then the perio chart and the pressure on the seal is specific to how far that perio gel needs to go.
Yes. And then, so the perio gel is a 1.7% gel. Just in the month of February 2021, they started adding in xylitol as well. So they now have Perio Gel X that uses xylitol as a sweetener, which is super awesome, as we know, for decay prevention, and just another great adjunct to using the trays. So that's something that's super cool that they just did. You can also add in doxycycline calcium mixture or Vibramycin liquid. And this is going to sound crazy to some of you because I didn't know this was a thing, but it can be used topically in the trays to stimulate antioxidants, as an antioxidant to stimulate osteoblasts to lay down new bone. You can literally rebuild bone with these trays. And I've seen it. I've seen it happen. I've seen teeth that were mobile go completely solid and stable and not mobile. I've had a doctor, one of our doctors who used to do our wisdom teeth extractions, would kind of yell at me and say, hey, if you want me to take those wisdom teeth out down the road, please don't put them on Vibramycin because it makes it almost impossible to get those teeth out. So it's really, really cool technology. Now, because it is using a peroxide-based gel, a really nice side effect of the trays is they will gradually whiten your patient's teeth significantly. It's not as fast, obviously, as doing a whitening type treatment because it's such a low dose, but over time, cumulatively, it's a very significant whitening.
Yeah, let's touch on the Vibramycin for a second. So I think that it's important to remember, I haven't had the anecdotal experience that you have. I haven't seen the bone regrowth, regeneration. And maybe it's just I haven't been using them long enough. Maybe I had we've been using them for 2 years. We know that bone is one of the slowest growing, things just like nerves and that sort of thing in the body. So I haven't seen that bone regeneration, but what I can think of for, skeptics and people who are like, what do you mean? Like what are you talking about? I can just kind of hear that because that's definitely my initial thought when I hear that. And if it weren't coming from you, I would have a lot of doubts. I'd be like, oh yeah, okay. But I want to just, refer to a couple of studies that have been around for quite a while, and I can find maybe we can find a way to link it to this podcast or something, because I don't remember specifically where this information came from. I just remember in hygiene school and reading recent articles about chlorhexidine versus doxycycline or minocycline subgingivally. Any tetracycline subgingivally, it would just be this comparison of chlorhexidine would inhibit that long junctional epithelium. So it inhibit fibroblasts and things from kind of reconnecting, even if it's a pseudo attachment. That's part of what we want to do, is to shrink the pocket. We want that inflammation to come down from the coronal portion, and we want that junctional epithelium to be long and form a pseudo attachment to the tooth so that the pocket is shallower and more cleansable for our patient, right? That's one of the things that we're trying to do when we do non-surgical periotherapy. But from the bottom of the pocket, it was found that chlorhexidine inhibits the pseudo attachment from happening. So we get less resolution when we use chlorhexidine. So I usually use that for patients that we don't need reattachment for, or we don't really need that long junctional epithelium. So that would be like my gingivitis patients I use it for, right? Because we're not trying to bring anything back from the bottom end. It's really just getting the inflammation under control. But if we think about the studies on Arrestin, and I know that that's in the tetracycline family, is that in comparison with chlorhexidine, and that by itself has been shown to one, boost the connection with the fibroblasts and like the little collagen fibers and things that actually form that pseudo attachment, but also does reinforce alveolar bone, the actual alveolar bone. So that is what makes me think and kind of tips me off to the fact that, there might be something to this, and gets me a little curious to see what happens, and I've prescribed the Vibramycin for a few patients, and they've been using it. I think my longest patient has been a year now, and I haven't seen that clinical anecdotal evidence, but I'm like really curious to see how that develops.
Average, it takes about 18 months. And I tell the patients, hey, it took a while to lose bone. It takes a while to grow bone. And typically that Vibramycin for application to regrow bone is going to be the patient wearing those trays twice a day to make that happen.
Well, that makes sense. Yeah. And even when we do laser assisted new attachment, protocol, even when we do LANAP and laser assisted surgery and LPIP and all that stuff, that's, how long it takes. We don't probe for a year. We're forming that regeneration, and then we take an FMX, and sometimes we see regeneration. Sometimes it takes longer. I think for the full result of LANAP, it takes about 3 to 5 years. Like I know it takes longer than that initial year. So that makes sense.
Yeah. So the Perio-gel, the whole purpose of the Perio-gel. So every patient that I have uses the Perio-gel. And what that does is specifically targets the anaerobes. So, obviously we've got the good healthy bacteria. Those are the
aerobes.
Thank you. And then we've got the oral pathogens, which are the anaerobes. And so those are what are hiding down in the pocket. It's warm, moist, dark, not a lot of oxygen down there. And what the trays do is, because it is in gel form, it forces that gel to the base of the pocket and holds it in place. We've got the positive pressure of the sulcular fluid coming out that's trying to, flush everything out. So you've got to have that positive pressure to hold that in place so that it can stay. And it honestly kind of debrides away any buildup that's down in there, and oxygenates those anaerobes and pops their cell wall and kills them. So it's a great way to get that into every single nook and cranny in that patient's mouth and eradicate what's actively there, but then create a community that they cannot continue to live in. So it's a very smart way of addressing those bacteria, which is really what's causing all of the problem. And you alluded to, it is definitely multifactorial. But if you can control if you can control the bacteria, you can control that patient's outcome. And so that's what these trays do.
If you can control one or more of the factors, it becomes a lot less, prevalent. And you basically undermine all the layers of the plaque and calculus lasagna.
Exactly.
If you will.
Exactly.
Yes.
So what does this look like? So, let's talk about who's a good candidate. And obviously I said, I feel like honestly, everyone is a good candidate, right? Because I personally don't want to have those anaerobes hanging out anywhere subgingivally. And that is why I use them. So obviously I think everyone's a candidate, but if you're just getting started and you're not quite sure, I think one of the best places to start is your active perio patients who have active disease. You see the bleeding, you see the redness and the inflammation, you see the bone loss. And then your patients who are perio maintenance that aren't really staying stable, that we're not really maintaining health. They're coming in every 3 months, but we're still seeing bleeding, we're still seeing inflammation. Obviously, we're not able to really control that microbiome and make sure that things are healthy. So I think that's the best place to start. Patients that have implants, it's beautiful because nothing's going to take your implant away except bone loss. So if we can prevent that, that's a beautiful thing. I also love it for patients who have a high decay rate, because you can also put in, we use Carry-Free 5000 gel as a prescription fluoride gel in our office. So I have some patients that alternate between wearing the Perio gel and wearing the Carry-Free gel. And it's great for patients who have a lot of recession, because again, it's holding that gel, it's forcing that gel all the way down around the roots. Obviously,
I've got the xylitol on top of that. That's great.
Yeah. Obviously, any of your patients who have systemic issues going on, you've got somebody who's, got arthritis, diabetes, uncontrolled diabetes, your heart attack, stroke risk, or previous history patients, your pregnancy patients. There's so many options for people that are great candidates. So you find your candidate, and then the process involves either taking your scan or taking your impressions and sending those off to the lab.
Can I add to the candidates?
Yeah, please.
We have similar but different kind of rationale at SPODAC. So because we have kind of a different modality than you, like we're multi-specialty, we don't really refer out. We do a lot of our own treatment because we've got the periodontist and the oral surgeon and the endodontist with us, on our team. So we refer to them in our practice. So we came up with a protocol, and actually, from what I understand, LANAP is regulating, like whoever regulates LANAP, wherever that came from, originated, has added Perio-protect or perio-medicament carriers, these trays, to their protocol.
Wow.
So from what I understand, that's what, I heard this from our former prosthodontist at SPODAC. So I'm just enlightened because of him, but we now include Perio-protect trays in every LANAP treatment plan. So anyone who's having laser assisted therapy does need to oxygenate the pockets, because we can't clean subgingivally for a year. We can't probe, nothing's getting down there. They need to oxygenate those pockets and kill the anaerobes without damaging the regeneration that's going on. So that is the safe and effective way to do that. So all LANAP patients is a great, someone who's great to implement it on. Anyone that I see in my schedule who has had a history of multiple treatments for their active perio. So that could be non-surgical therapy, that can be surgery plus non-surgery, it can be multiple surgeries, it can be, just different things that has been ongoing. I can explain to them, hey, this has been a roller coaster. Every time this is active, it is cumulative damage. So you lost a little bit of bone, we arrested it, now you're losing a little bit on top of that. So eventually we're going to come to the place where teeth become loose, and then we don't really have options for keeping them and saving them. We'll have to talk about replacing them at that point. So let's try this, because guess what? We've tried a lot of other things. We've modified your home care. You're doing your part at home. We've got to get something else in between the times that you're seeing me to disrupt those bacteria, kill the bad bacteria that are remaining active, that are causing this to be really this roller coaster ride, this cyclical problem for you. And usually patients are like, yes, I've invested like $50,000, like something crazy, if they've had surgeries and treatments, like this is a no-brainer for them. So anyone who's had multiple treatments in the past, anyone who we do salivary testing on who has a refractory perio is a big thing for us. And we do a lot of salivary testing. Our periodontist does a lot of salivary testing. If they have refractory perio, they're getting perio trays. Anyone who does full mouth restorative, all those crowns, the margins, we need to maintain the gum tissue around them. That is like no brainer for that too. So I just want to throw out some other ideas, because yes, definitely. I agree with Charissa, like totally. It's a preventive, it is a treatment modality, it's a maintenance tool. It is like this highly dynamic thing. But I think that all of those patients are great candidates. And I also want to tie back the candidates. Sometimes we have to think out of the box in order to address the patient's chief complaint, right? So if a patient comes in and their chief complaint is, I want to whiten my teeth, right? But they also have perio disease. They're not as interested in that. They don't see the value in treating that as much. And they're really just set on like, oh, let's whiten the teeth even after being educated. This is the route that I would use to do that for that patient, right? Because we're getting from the health aspect what the patient really needs. They're getting what they need. And also they're getting what they wanted as well. They're getting their white teeth. So I think it can be used in that way. There are just so many things that I can think of, in so many ways, that specific patient scenarios that I can think of that we've enrolled Perio-protect, and it's just been like the best thing.
Yeah, 100%, 100%. So, like I said, you'll get your initial scan or impression, send that off to the lab. It typically takes about 3 weeks to get back to you. Now, here's another interesting thing is, and I know Brittany and I do this a little bit differently. So I work in Georgia, and I am very limited with what I can do treatment wise for periodontal disease. I obviously can do scaling and root planing. I cannot anesthetize myself, so I've got to get the doctor involved for that. I cannot touch a laser. So I feel like I'm kind of tied. Now, for me personally, because of what I know and understand about perio and all the connections systemically, and I know that whenever I'm performing non-surgical periotherapy, and I'm creating all that bleeding, I'm creating that bacteremia, I'm introducing all of that bacteria into their bloodstream at once. And that is something I'm not super keen on. And I make sure my patients understand that if we go that route, that's the reality of what's happening. So because of all that, I like to use Perio-protect trays as my initial therapy. So for me, I will have them wear the trays for 4 weeks before I go in and do any kind of scaling and root planing, because I really want that bacterial community to be diminished. I want to see less inflammation and less bleeding. I think it's just a much healthier route to go. So that's kind of how I start in our practice. And then they'll wear them 3 times a day for 10 to 15 minutes for that first 4 weeks. They come back in, I reassess. I'm taking a new perio chart. I'm seeing, 1 to 2 millimeters, sometimes 3 millimeters less of pocket depths. And that's, that reduced inflammation and less bleeding and less tenderness for the patient. And then I'll go ahead and do my therapy. And then I have my patients wear the trays twice a day for the next 3 months. And then as we go and as we see them heal and progress, once my patients are stable and I'm not seeing any inflammation, I'm not seeing bleeding, everything looks really healthy, we've regained the attachment we want, then it's once a day for 10 to 15 minutes long term.
Okay. And I have a couple of questions because we treatment plan that we do this a little bit differently, I know. So you treatment plan, I know, before doing scaling. So that goes for patients with like gross calculus accumulation too, like a lot of calculus, super gingivally.
If I've got somebody that has a ton of buildup, then a lot of times I'll go ahead and just remove that supragingivally because I want those trays to fit long term. So I'll do more of a gross debridement for them first so that I can have access to the gums, and then I will take that scan.
So do you, in any instances, treatment plan 2 sets where you'll do a set before and then treat and then a set after?
Great question. I will do that for patients who have more severe periodontal disease. So if I've got a patient that's got, 7+ millimeter pockets, what I know about the ability of these trays is it's really going to reduce those pocket depths and that inflammation to the point where it's really going to change the anatomy and the topography of the gingiva. So I know that as things heal and get healthy, those trays and that seal aren't going to fit as tight. So for those kind of patients, I do let them know like, hey, either we've got really exacerbated inflammation here, or we've got really deep pockets. And as things heal, it's going to change. So I want you to know that, we're going to get to a point where these trays aren't fitting as tight, that seal isn't happening anymore. Then we're going to make you a second set of trays.
And 3 millimeters is the rule of thumb, right? When there's a reduction of 3 millimeters or more, that's really when the trays start, like, they're not as effective. Isn't that kind of the...
Give or take, yeah. And it depends on it depends on how much inflammation and infection, how many pockets there are. Because if you've got one site that's reduced by 3, the rest of the tray is still going to fit really, really well. So it just kind of depends case by case.
Got it. And I just want to mention too, because I know what the effect is on calculus, but when you do this pre-treatment, what does it do to the calculus when you actually go to scale? Oh,
it definitely softens it up.
Right.
And it's the peroxide, that ability to kind of bubble away at the debris, and it kind of eats through it. And that's why I have my patients wear them 3 to 4 times a day at the beginning of treatment, is because it's literally kind of eating through those layers and it's breaking it down. So yeah, it definitely comes off a whole lot easier.
Yeah, it makes the tenacious calculus like brittle. And you'll notice that with recares too. So recares who wear it and who are still accumulating calculus, like we know that they do despite their best efforts, it's just brittle. It just flakes right off.
Right.
Yeah.
Yeah. So yeah, really, really, I don't have anything bad to say about it. Everything around has made my job easier and my patients' lives better. And it's, people ask about, well, what about, the patient compliance? What does that look like? And I think, as with everything, you have some patients that are, going to come off and on, I had a patient Friday that was in. It was like, hey, how are you doing with your trays? And they're like, well, I was doing really good until I took a trip and I forgot my trays. And then I've come home and I just haven't gotten back on track. That's the reality of things. But I would say 80% of my patients are pretty darn consistent with it because they've seen the benefits. Their mouth feels better. The tenderness is gone. Their teeth are getting whiter. Yeah, they definitely stay with it because it's working for them.
It's cool because this is the one thing I feel like, and people ask all the time, well, if my patient's not like great at flossing or they're not taking my home care recommendations, are they likely going to wear the trays? I mean, that's on a case by case basis. Like clearly, if someone's not committed to wearing their aligners during Invisalign, they're not going to wear the aligners if they're not committed to flossing or brushing. And we see that over and over again. But I have just anecdotally seen a lot of patients who aren't the best with home care, who kind of like refuse to floss but are willing to try the trays, and then they notice the difference like in their own mouth, and they notice either less bleeding, less tenderness, their gums look different to them, which I know is like very uncommon. People don't notice the way that their gums look, but I have had some patients say like, oh wow, my gums actually look like they look, I don't know, they just look different. They look not as red or not as whatever, they notice these things. And it's just, I think it's the thing that patients can see the biggest change, because we can see the change when they start flossing and brushing and that sort of thing, but they don't get the tooth whitening. They might not notice as much like the difference that it's making, but I feel like people really notice more with the perio trays for some reason.
Right. Yeah.
I really do. So you want to kind of get into the ins and outs of like what a Perio-protect onboarding enrolling protocol might look like?
Yeah, let's do it.
Did you have anything else clinical that you wanted to share on that?
I don't know. If I think of something, I'll hop in with it.
Okay. So we came up with, so at SPODAC, this is all, we'll go over our kind of like protocol. And by the way, your verbiage is in here and it says, by Charissa Wood from Atlanta Dental Spa. This is what we say to educate patients on Perio-protect because she is the ultimate resource for this. So Perio-protect in our protocol, we explained, what it is and what it isn't. So it doesn't replace non-surgical periotherapy, LANAP, laser-assisted surgery, or traditional perio surgeries in general. Sometimes it can, if we try it as our initial modality for treatment. Sometimes it can keep patients out of that boat. And if we can do that for them, great. But a lot of times it's an adjunct to those things. So like I mentioned before, it's an adjunct to the laser. It's an adjunct to scaling and other treatments and removing and debriding the calculus and the disrupting the plaque biofilm and all that stuff initially. It's an intraoral tray system that uses suction over teeth. So we define what it is. We define what can be used in it, like Charissa just went over. We also define the differences between perio trays and night guards. So a night guard is hard acrylic material, is on one arch and not the other. You don't wear it on both. It doesn't cover the gingiva. It's not meant for that. Clearly, the perio trays clearly cover the gingiva, have a completely different function. You use a medicament in it to serve a completely different function. So this was information for our team, but it's also great information to think of for patients and be prepared for patients to ask, well, I have a night guard. Can I just use that? No, you can't. It doesn't have the same design. It's not specific to your gums. It doesn't serve the same purpose at all. Like these are specific. Here's why.
I want to add something very quickly.
Yeah.
That popped in my head because I've had a couple of patients ask me.
Mm-hmm.
I actually had a patient this week who asked me, she said, well, I've got an event I want to go to and I want to see if I can get my teeth a little bit whiter for that. Can I just use my whitening gel in my perio trays? And my eyes got huge. I was like, no, you cannot. So obviously anything you put in the trays, because it is forcing it subgingivally, we do not ever want to put whitening gel. That would be really, really uncomfortable for you. So just wanted to throw that out there as we're thinking about options and things that we can use in the trays. I also want to say that you want to avoid putting anything with oils into the trays. I know we've got patients who are big fans of oil pulling and, that sort of thing, whether we are or not. And if you put oil into the trays, it can break that seal, release that seal so that it's no longer as effective. So just a couple of little things I thought of there.
Yep. Thank you for that. The next thing that we went through, so we defined, what's Perio-protect, how can it be used, what it is, what it isn't, and then steps for implementing Perio-protect for patient care. So that's what Charissa went over about determining who is a candidate, and we went through who's a candidate, rationale for recommendations, which is what we've already reviewed. The next thing is patient education. So we defined the verbiage that we would use to help enroll patients for Perio-protect. And Charissa, maybe you can go through some of the verbiage that you use because you enroll it so well and educate patients so well. Do you want to talk about how you bring it up with patients and how that typically goes? And
So, and you know me, I know we talk about that we're not robots a lot, but I feel like sometimes I am kind of a robot, only because I've created very specific verbiage for things, and I just that's my go-to. And I feel like I just designed it in such a way that makes sense to people. So the very first part of enrolling Perio-protect is helping your patient understand and own their condition. So I'm really big on, as I'm doing all of my assessments, I'm taking my x-rays, I'm taking my photos, I'm doing the perio charting, I'm involving my patient in all of that so that they can see and understand what's going on in their mouth. You know, we all are very, very, very aware of how much periodontal disease can not hurt and not seem like a problem. And so many patients, you know, you do all your assessment, you're like, hey, I got to tell you, you know, we've got some infection going on in here. And they're like, wait, what? Nothing hurts, nothing bothers me. So it really takes involving your patient in that whole process. So showing them on the x-ray, pulling that up, showing them the bone loss, showing them the redness and the inflammation in the photos, you know, having the conversation with them that the bleeding that they're seeing when they're flossing is not normal and not healthy. And then when I perio chart, I always say, you know, I perio chart out loud so that they can hear those numbers themselves, you know, and I preface it with, hey, I'm going to go ahead and check the health of your gum and bone. I'm taking measurements around the gum line. You're going to hear me calling out numbers. Anything from 1 to 3, that's normal and healthy. That's what we want. Anything 4, 5 or above, or any areas of bleeding indicates some inflammation and infection. So that by the time I'm done with all of that, they have heard for themselves. You know, they can tell me, ooh, that didn't sound very good, or ooh, we got a problem. Then I sit them up, because this is the other thing. I think it's important to not say this while they're kind of leaned back at your mercy. Sit them up. Let them feel comfortable. Let it be a conversation between two people. And I just say, hey, I'm really concerned. You heard me, you know, you heard me calling out those numbers. Let me tell you a little bit about what those mean and what's going on. So where you hear me say 4s, that's where we have some inflammation. And that's basically, so let's think about this. We have a lot of healthy bacteria that we want in our mouths. Well, sometimes we get exposed to some of the bad bugs, and those are typically anaerobic, meaning they don't like oxygen. So they really like to hide down below the gum line. It's warm, moist, dark, not a lot of oxygen. So they hang out there and they set up camp. In doing so, they start secreting toxins, and that initiates the inflammatory response. So your gums get a little puffy, swollen, may feel some tenderness, see some bleeding. I know you mentioned that you've been seeing some bleeding. This is an infection going on. The areas of 5s or 6 that you heard me say, that's where this infection has been going on long enough to where those same toxins have started to dissolve the bone underneath your gum. Let me show you on the x-ray. And, you know, I've got that on the screen for them, and I'm showing them where the bone height should be versus where it is. I said, I'm really concerned because obviously this is a condition that will continue to degrade your bone around your teeth. You know, obviously from a dental aspect, we want to keep your teeth for the rest of your life. But if we start seeing that bone head south, if we lose enough bone, we'll lose supportive teeth and you can lose your teeth. Where I get more concerned are the systemic ramifications, because when we have this kind of infection going on and we've got that active bleeding happening, or we're chewing on inflamed gums, that releases all those bacteria and all those toxins directly into your bloodstream. And we know there's so much research that's showing us the connection between, there's about 12 different types of bad oral bacteria that they've seen implicated in things like heart attack, stroke, diabetes, arthritis, certain types of cancers. So I want to obviously, you know, I want everybody to have a smile that they love and they're really happy to show. But more importantly, I want to make sure that there's nothing happening in your mouth that puts you at greater risk for your overall health. This is also where I will tie in any personal issues from their medical history, lifestyle issues that they have going on, and I'll tie those in and bring that in to help them understand how this connects for them personally.
Their chief complaint.
Yes, yes. So we've got a couple of ways that we can address this. Because I think it's important that you give your patient options so that they feel like they have choices to make here. But I always tell them what I think the best option is going to be first. So, you know, I'll say, I think the very best thing we could do for you is make you something called Perio-protect trays. And that involves me doing a quick, easy digital scan. I send that off to the lab. It takes about 3 weeks to get there, get made, and get back to us. You'll come back in for about a 5-minute appointment. It's just making sure the trays fit and feel comfortable, showing you how to use and take care of them. You will wear those trays 3 times a day for 10 to 15 minutes. So while you take your shower in the morning, if you can catch it around lunch or dinner, and then before you go to bed at night, you'll do that for 4 weeks. And I know that that might seem like a lot, and that might be a lot to ask, but if we think about the fact that we are in active infection stage, this is how we're going to treat that and get that stopped. At the end of that 4 weeks, you're going to come back and see me. I'm going to recheck our perio charting just like we did today. And at that point, I expect to see a reduction in the pocket depth and the inflammation and the bleeding. And at that point, we'll kind of determine what type of cleaning we need to do. Sometimes these trays do a really, really great job if you're doing a great job with them. And I might not need to do as much. So we'll determine based on your healing. We'll do kind of a deeper cleaning at that point, what we call scaling and root planing. And then we'll determine how frequently you need to wear the trays based on how you're responding and how you're healing long term. My goal is that as we get things really, really healthy and stable, you'll go to where you're wearing your trays once a day for 10 to 15 minutes. There is a side effect to these trays that it does gradually whiten your teeth pretty significantly. So that would be our very best, treatment for you. The alternative to that would be doing what we call scaling and root planing, or that deep cleaning. And that's where I'm going in all the way to the base of those pockets and scraping and flushing as much of those bacteria out as I possibly can. I'm going to be honest with you, doing that does kind of create what we call a bacteremia, where it's stirring all that bacteria up into your bloodstream at once. And I know I'm not actually sterilizing anything. So I know I'm getting a lot of the bacteria, but I'm not necessarily getting all of them. So in those cases, we have to be really, really thoughtful of how we're going to target your home care toward those areas, because they become really, really hard to reach for you, which is why I'm a bigger proponent of the trays. I just gave you a ton of information. So tell me, what do you have questions about? What are your thoughts? Where do you think you would like to go from here? And then I'm really quiet.
So you've never done that before, huh? You're a complete rookie. It sounded completely unnatural and unfamiliar to you.
I feel like I could do that in my sleep.
I feel like you definitely could. I think I have heard the exact, but every time you say it, it's very like authentic, and like you're really connecting with the person and you tie it back to their chief complaint. But like clearly, I want to touch on just a couple of things, because you did just do a lot. You just demonstrated a lot of things. And I think that there are some really, like, you just gave us like golden nuggets in regards to just enrolling patients in general, not just in regards to Perio-protect, right? So the first thing is you reviewed the problem first, right? Problem, what's going to happen if we do nothing, the long-term implications of not treating the problem, and then here are the possible solutions. I didn't notice any point in time when you brought up the cost.
Correct.
Right? So correct. Okay. So why is that so important? I think that this is an important thing to touch on with the Perio-protect trays, because it is a quote unquote higher price tag if it's coming from the hygiene department. It is one of our more quote unquote expensive treatments that we offer. So what is your thought on not bringing the cost up, and what is the thought on, well, let me tell you, I'll tell you my thought. My thought is, because I can't contain myself, I'm sorry, that was just so beautiful, is of course, we want to present the problem, the solution, everything that we, the problem, challenges, question, solution, do all of that stuff, because in the grand scheme of things, the money is the least important thing, right? It's the least important thing. We want to get our patients healthy. That's our come from. So we're going to talk about all those things first. And we want to let them understand the value before we put a price tag on it, because then they can decide, okay, do I value that enough? But if we put a price tag on it first and we make that a barrier, then they're not going to hear the value. They're going to get stuck at the trays cost this much. And then they're not going to hear the rest of what Charissa said so beautifully. So that's really important. Another thing that you did is you let the patient hear, you let the patient see by showing them the photos, the radiographs, and then you let the patient, I know that you would show them a model of the Perio-protect and let them touch the trays a lot of times as well. So you're engaging multiple senses there.
I didn't say this because I wasn't actively doing it, but if I have a patient who, obviously is tender when I'm perio charting, I kind of use that to say, oh, that's tender. I'm like, yeah, that's really common when things are infected. It's again, them feeling that and putting that together, like that's not a normal thing.
Yep. You said, I'm concerned. There's infection. You noticed bleeding. There's bleeding here. These are the things that I look for. You pre-framed so that they knew what to listen for. So they were engaged in the entire process. So, and then you asked an open-ended question at the end of all of that.
Right.
What questions do you have? What are your questions? So I just gave you a lot of information. What are your thoughts on this? So all of those things I think are key in enrolling any treatment, but especially perio, which is like no one comes to the dentist like, hey, my gums hurt. That's happened a handful of times, right? Sometimes there is an acute inflammatory problem or there's NUP, there's something going on, or there's, something, a popcorn kernel lodged somewhere. But other than that, no, patients don't come like, yeah, I think I have a problem with my gums. I think they're inflamed.
Yep. There are a handful that do, and that's when I get super excited when like I had a patient a few weeks ago and she came because when she's bleeding, when she's brushing, her teeth are bleeding profusely. And I'm like, yes, I got an answer for you. We're going to stop this. This is going to be great. Yeah. But you're right. Most people don't have any idea. I think if you took a survey of Americans, I think the majority of Americans think that pink in the sink is normal. When they brush and floss, that's like, oh yeah, I bleed a little bit. They don't think that that's a problem. But if, you were to brush your hair and your scalp started bleeding, that would really put you on edge. So I think, we've got to battle that mentality.
Yep. That's an analogy that I know Ashley that I work with loves to use too. That's a great analogy. All right. So that's in regards to enrolling and verbiage. And in regards to treatment planning and fees. So the Perio-protect code is D5994. It's periodontal medicament carrier. It's actually a medical code, right? So medical insurance will sometimes recognize this code for some reason. I'm not sure why it's not recognized by dental insurances, but I know that we tell our patients, if you want to investigate, coverage or see if they'll contribute to some of the cost of the trays, you can, call your medical insurance company. Here's the treatment plan. Here's the code, and you can investigate on your own time. They'll cover up to 50% of the trays.
Right. And I feel really embarrassed because I don't have it in front of me right now, but the codes actually changed as of 2021.
Oh yeah, they did.
They now have a code for maxillary and a separate code for mandibular. And I think it's like 5995 and 5996.
I think so too. I think you're right. Yeah, it's the same beginning, but yeah, you're absolutely right. They did just change. All right. So that's the code. In regards to scanning or impressions, like Charissa said, that's how you really get the ball rolling. So we both do now digital scans with iTero. It is, we do an iRecord scan. You need about 6 millimeters of gingiva, and you do need to get the distal of third molars, second molars, everything, as much gingiva as you possibly can, because we want an adequate seal.
And if you don't have an iTero, because that's fairly new to us, we just started that at the end of last year. So if you don't have iTero, you can send impressions. You want it to be the monophase light body impressions. Obviously you're not going to send alginates, but impressions need to be really good. Like Brittany said, you need to really capture the gingiva about 5 to 6 millimeters beyond the gum line. And you don't want to have any pulls. You want everything to be really, really exact. That's important because these trays are so specifically made. You can pour up your own models and send those in. Again, everything just needs to be really, really exact and well done. There is a little bit more of a fee. The lab fee, they do have a lab fee for either pouring up models or printing out the scans, just depending on how you go.
Yeah, and I would say I just want to give a ballpark or a cost frame of reference here. The average cost for trays to the office is in the realm of $200 to $300, depending on whether or not you include home care systems and the first gel and all that stuff. So that's where that bracket comes from. The average cost to the patient is, I think, $800 to $1,200, around there in that bracket.
Is the national average, but I know there's offices that go up to $1,200 and $1,300. It's just kind of deciding what area you're in and what your practice wants to do for that.
Right. And the trays, as long as there's not a significant change in a person's dental topography, meaning they don't have extractions or get a full mouth rehab or a significant change in, the shape of teeth or anything like that, the trays last 5 to 10 years as long as the patient takes good care of them. So it's not like retainers. And something I tell my patients, this isn't an investment that is going to be continuous. It's not going to be like retainers where you have to replace them every 2 years. They'll last 5 to 10 years as long as nothing significant happens in your mouth. And it's a long-term investment.
Yeah. And as far as the Perio gel and the Vibramycin go, We carry those in our office, and we do that because we do so many trays. And I feel like it creates some accountability for patients when they come in and I say, hey, do you need some gel? If their answer is no, I know they haven't been wearing them. So it's a good way to, kind of keep them on track and keep them going and monitor that they're actually using them. But we order that from Dakota Pharmacy. We keep that in stock in our office. If you're just newly starting and you're not sure that you want to have that going on, you can actually call in a prescription for your patient to Dakota Pharmacy, and they can get it through them directly. So there's a couple of different options there. I also like to keep it in the office because when I'm delivering their trays, I want to be able to give them everything they need to get started.
Mm-hmm. Yep. So whether you're scanning or taking impressions, if you're either way, you need to submit a paper script, right? So if you're scanning, you can fax it over. If you send impressions, Charissa, do you just send that with the impressions?
Yeah.
Okay. So you send the paper script with the impressions. Okay.
And when I do the scan, I actually email. I email both the lab script and the perio charting together.
Gotcha. We fax, so I guess you could do it either way, whatever is more user-friendly for your office. And then in regards to delivering, I know Charissa touched on earlier, you said it takes about 2 to 3 weeks for the trays to come back once you submit that scan and it arrives, or submit that impression and it arrives. But I know with the pandemic, our turnaround times have been a little longer. They've been like 4 to 5 weeks. They've been a little slower than usual. I'm not sure if it's because of the volume going through or the personnel and just people coming down with COVID or what, but we've been having a little bit of a lag. So right now we're at about 4 to 5 weeks for the turnaround, but it's a great idea to schedule that delivery appointment so that they're on the books. They make sure to get their perio trays.
Yes.
We usually collect at least half up front or in full up front. And then upon delivery, they either owe half or zero, or we formulate an in-office treatment plan for them if that's what is necessary. And we schedule about 20 to 30 minutes for that delivery. And Charissa, do you want to go through your verbiage for delivery?
So sure. I always try them in first to make sure that they've got the proper seal and they fit comfortably. There are times where if the patient has maybe some exostosis or some tori, or they've just got thinner attached gingiva, that there's been some areas, or even around like the very back, very distal of the molars, where they think things feel like a little too tight or pressing too hard, and you can almost see like the tissue blanching a little bit. I have been able to adjust the trays. I use a hot knife for that. You want to be very, very careful to not adjust anywhere near to the seal, because obviously that's what makes them work. I've also sometimes seen, though, if there's a little bit of a flange on the very distal, it might not want to seat all the way down. If I can take that hot knife and take that extra little flange off, it'll seat. So making sure they're fitting right, and I'm sticking my gloved fingers in, making sure that the seal is happening. Making sure the patient's comfortable. I literally open the gel, unscrew the tube, tell them, we got to cut this tip off, screw it back on. I've had patients, if you don't really tell them all these things, like I've had patients cut through the end of the screw tube, and then there's no way to seal their gel off afterwards. So all the little things. Basically what I instruct them to do is just make a thin line of gel from one molar to the other around in the tray. If we're incorporating the Vibramycin as well, and again, that's really, I'm only using that for patients who have really exacerbated inflammation, that will take it down very quickly, or more significant bone loss. So it's really, and because it's a liquid and it's hot pink in color, you can't miss where it's going. You just put a drop kind of around the tray, or if it's just one quadrant, you can just put it in that area and then put the trays in. They're gonna wear them for 10 to 15 minutes. And then when they take them out, they're going to gently brush off the gel, rinse the tray under cold water, and lay it out to dry. And there is, like Brittany said, there's some options you can get through Perio-protect, where you can get like the little patient care case that comes with them that like they can hang them in, which is really nice. I do ask them if they have dogs at home, because I've had several trays become really expensive chew toys. So, if you've got a dog at home, for some reason they love these things, keep them high up and far away. And to only use cold water to clean them, because hot or warm can warp them. I've had a patient who put them in the dishwasher to clean them, and they did not the same.
Well, that was a good thought. They just wanted to sterilize. I mean,
yes, I thought it was, they're trying to be helpful.
So you just went through the exact, not surprisingly, I'm sure I got this from you, the exact protocol that I use too, that tends to work best. And you just went over what not to do first. So this is the part that people, I think, pay the most attention to. There's only like really 3 don'ts. Don't use warm or hot water. Don't use gel, oil, or paste that I don't give you. Don't use anything other than prescribed because, like you said, it can ruin the seal. And don't leave them out where a pet can access them.
Yep. And that's pretty much it. So, they'll lay them out for their next wear and brush the gel off their teeth and go about their day.
And usually when I have them try them in, they do blanch the gums, even in areas where they're not fitting too tight, even just where the seal is. So I like to show the patient like, hey, this is completely normal. Your gums may appear white. Is anywhere pinchy or pokey, anywhere bothering you? And then that's when we'll do the adjustment. But I want them to know that that's normal. And also, like you said, you make sure that they're seated all the way to make sure that they fit, but also that the patient gets that feeling of like, this is like a diabetic leg stocking. Like it's supposed to be very snug.
That's tight. Yeah.
It's very snug. So you want them to know that that's normal. And then, I don't actually dispense the gel either, but I show them, molar to molar all the way at the bottom. You don't want to get the gel in the seal because that defeats the purpose kind of thing. You show the patient, big teeth on top, small teeth on bottom. This is how you determine the upper and lower trays. You wear them for 15 minutes. No, you can't wear them for 30 or 45.
You have those patients that come in and they're like, I'm an overachiever. Like I couldn't do it twice a day, but I did it once a day for 40 minutes. I'm like, that's awesome. Except the gel is pretty much done with its job at about 20. So
that 10 to 15 minute time frame is when it's most active and when the patient's actually getting the most.
I will say too, if you're questioning, like, I don't know about you, Brittany, but for the adjustment, I might have to adjust 5% of them. Like that's not a common thing that I'm having to do.
Yeah, it's a low percent. I would say ours is a little bit higher, and it's a little strange. I don't know if it's something with the iTero or the scanning or something. I would actually think it would be opposite with alginate impressions and the distortion that happens with those with humidity and stuff. But I think that ours is maybe like 10%, I would say. Still pretty low though, and it's very straightforward. And usually it's an immediate relief type of thing, just like adjusting a night guard or adjusting a crown, occlusal equilibration or whatever. Usually they're like, oh yeah, that's much better. So, and also I want to add photographs. So photographs before, during, after, follow-up. The follow-up is generally 4 to 6 weeks. We have them come back in, do a periodontal chart, or sometimes if their maintenance is in 2 months, I'll just wait till their next maintenance, and reeval at that visit, update some photographs. But I like taking the photos because that's really the best. It says 1,000 words, like Charissa likes to say,
and it encourages the patient when they can see the changes.
Yeah, absolutely. Yeah. And I have a patient that I can think of off the top of my head who recently, he's had ongoing perio issues and has been kind of steadfast in not wanting to move forward with a whole lot of treatment and resolving, and doesn't, follow home care recommendations. And every 3 months, it's like a mountain of calculus buildup on those lower interiors, the facial and lingual. And it was interesting how he actually complied to wearing the Perio-protect trays. So we talked about him extensively, talked about, rescaling, and he was just barely overdue for his home care, and his perio disease was just off the charts. Like it was so incredibly active that we were like, we have to retreat this. You're in treatment mode now. And it was only like 5 months since his last recare, just the poor home care and the calculus accumulation. So talked about rescaling and Perio-protect trays and how, we want to minimize the need for treatment. So he was enrolled. He was a little grumpy pants about enrolling and saying yes. And like, oh my God, this is expensive. And like, why are we doing this? And is it necessary? And I've known him for a long time. So I was just very straight with him. I was like, yes, it's necessary. Yes, this is what's best for you. Let's do this. I'll take pictures. I'll show you next time. Like, I was just like, just trust me, do it, do whatever you can. And let's look at it together next time. So we took the photographs that day, and then did the scaling, and then took follow-up photographs in 4 weeks, and then at the 3 month. And it was just insane, the change, the reduction in inflammation and redness at the gingival margin, the reduction in calculus accumulation, even though the patient hadn't changed his home care besides adding Perio-protect trays, the whiteness of his teeth. And it's funny because I asked him, I'm like, I can just see clinically the change that's happened before even perio chart. I'm like, I haven't done the numbers yet, but clinically I can see the change that's happening in your gums. Have you noticed? He said, no. I pulled up those photographs, and I could see the light bulb go off in his head, and he was like, oh, like he really got it at that moment. And it was a person, who we'd been on this kind of rough road with, who had been a little stubborn and hadn't accepted the treatment and had difficulty kind of believing it. And it was a cool aha moment.
Nice. That's awesome.
Yeah.
Awesome. Yeah. There's definitely, I think we could do a whole nother podcast of just the stories that we've seen, the individual patient stories that we've seen. I've seen multiple patients' A1C levels come down because we're treating that source of chronic inflammation. I've seen patients with arthritis who stopped doing hobbies go back to doing them and then finding that joy and that life again. I just think it's incredible what they can do for people outside of just reducing, the plaque levels and the bleeding,
I've seen a lot of improvement in chronic fatigue, believe it or not. So a lot
for
of
sure.
patients
That makes
are just
total
like,
sense.
yeah, like I'm just like, man, I'm always tired, man. I'm just, and we've ruled out OSA and ruled out other things kind of thing. And then they start wearing perio trays and they're like, I just feel better. I just have more energy. I feel like I'm just more awake during the day. And it's just like when you're not fighting that low grade chronic infection, just at a basic level, you have room to thrive.
Yeah.
Yeah.
So I want to, we could talk all day because we love this and it's super, super effective. I know sometimes the dollar signs are what speak when a practice is considering bringing something in and what can that benefit. So I want to just throw out some numbers for what Perio-protect can bring in. So if you were doing one set of trays a week, your new annual revenue that you're going to add is $38,400, which brings in a profit to the practice of about $2,400. So that's just doing one set of trays a week.
You mean profit is 24,000?
Yes.
So, okay. Okay, got it.
Yeah. So, that's just a small thing to think about, but that's just one tray a week, but that's, you're making a huge impact in the patient health care as well as the profitability of the practice. So something really to consider.
Yep. I think you're right. We could go for hours on that, but with that, do you have any other pressing?
What I have is, if you are listening to this and number one, if you want more information, like I said, Brittany and I could talk about this all day. And I've had some of you already reach out to me through our Mighty Network and ask me, some specific questions about Perio-protect and how to get that going. So we love to help kind of coach you through that. But you can start off getting more information. If you go to the website, it's providers.perioprotect.com/bulletproof. Then you will kind of be going through us and it gives you a little bit of a discount. There's tons of information there about how it can benefit, how the process works. But that's where I would start, is check that site out. And then obviously come visit us on our Mighty Networks, come join our community there, ask us questions. Tell us your success stories. Like, let's get into it. Let's have some fun with it.
Yep. And as always, remember that we would love to see your face in person this coming July 2020 in Austin for our Bulletproof Summit. And if you're interested in connecting with us in that way, go to bulletproofsummit.com. It's information about registration, exact dates, ticket costs, and you're able to get more information and register there.
And do you know what, Brittany?
What?
All of our attendees become Perio-protect providers at no cost to them.
I think that's probably the biggest icing on the cake. Yep. I've heard recently. Yeah.
Awesome. So everybody have a great week. Reach out if you have questions, and we'll see you next week.